So good noon, everyone. So my topic is on nutritional support in childhood solid tumors. But this lecture would also uh, include nutrition in pediatric oncology as a whole. So when you say you're giving the right nutrition, you're giving balanced source of energy and nutrients that our body needs. And this is important for cellular biochemical reactions to occur in our body and also for protection against damage. And nutritional requirements would vary depending on the different life stages and also the different conditions one has. So when you say nutrients, that would include your macro nutrients, which are your carbohydrates, proteins, and fats, and your micronutrients, which are your vitamins and minerals, and also water. So any excess or deficiency in the nutrients that we get would lead to malnutrition. So malnutrition in pediatric oncology, uh, the prevalence would depend on the type of tumor, right? Like for example, leukemia, the overall prevalence is around 5 to 10%. But you also, aside from undernutrition, you also have overnutrition among leukemic patients. For solid tumors, the prevalence of malnutrition is around 35%. And this is another prevalence study on the prevalence of malnutrition in solid tumors. And you have here adrenal and liver biliary tumors as having the highest number of malnourished cases in pediatrics. So malnutrition happens in our oncology patients because of inflammation, because of additional uh, energy requirements to increase metabolic demands, and also due to change in physical activity, and also due to the toxicity and side effects of treatment. And when you have malnutrition, no, you will expect a decrease in the quality of life, and there will be abnormal muscle strength, and also the risk of developing other diseases, no, like your infectious and non-infectious diseases. And uh, drug metabolism is also altered uh, due to malnutrition. And we don't want that to happen in our pediatric oncology patients. And malnutrition would uh, occur, no, depending on certain factors, uh, like the tumor type and stage. So more aggressive tumors and more advanced stage, malnutrition increases, and also depends on the intensity of the treatment, uh, the patient's body itself, and also socioeconomic status, you know, of the family. And in malnourished children with cancer, um, survival is poor, especially if there is more than 5% weight loss in the first 3 months, or more than 10% weight loss after 6 months. So you see here that malnutrition, no, would you would uh, assess, no, and detect malnutrition by getting your anthropometrics, no. But you could also determine the type of malnutrition due to its etiology. It can be either illness related or non-illness related. So for cancer, no, it's usually illness related. But if you also have socioeconomic concerns, then it would be also a combination of non-illness related cause for your malnutrition. And if your malnutrition has been there for more than 3 months, we consider it as chronic. And if it's less than 3 months, it's acute. And you have different mechanisms for your malnutrition. It can be due to starvation. It can also be due to malnutrition, malabsorption, nutrient loss, and hypermetabolism, and also due to inflammation. And it can malnutrition can be either due to problem with your caloric intake. It can be either excess or a decrease. And you could also have, on top of your caloric problems, are your micronutrient deficiencies. And all of this would lead to the effects of malnutrition in our patient. So by using that schematic diagram, we could the ideal way to classify malnutrition is by putting there the anthropometry. We could either say the patient has normal nutritional status, or moderate wasting, or severe wasting. If it's illness related or non-illness related, based on its etiology. Chronicity also you have to put there, if it's acute or chronic, and mechanism, and also the presence of micronutrient deficiencies and the expected outcomes of our patient. But usually this is what we put as diagnosis in our front of chart. So going to your assessment, nutritional status assessment. So it's important to assess and reassess our patients, especially our pediatric oncology patients, if they are in intensive treatment, or if they are already at the start high risk for undernutrition, then reassessment should be every 3 to 4 weeks. And if the patient is already in maintenance chemotherapy, we could reassess the patient every 3 months. But if the patient is critically ill, then we probably would need more frequent reassessments. Okay. And also, it depends on the nutritional risk. Later on, you will see how to classify your patient nutritional risk using your subjective global nutrition assessment tool. So if there's no nutritional risk, then every 6 months, or twice a year, or then annually, in our patients who are already after chemotherapy, or after treatment. And then also, if there's presence of nutritional risk after your chemotherapy, then we follow up more often. And if the patient is undernourished already, then we do monthly assessment. And if the patient is obese, then we follow up every 3 months. So how to do your nutritional assessment? We could make use of your ABCD method. So your anthropometrics, your biochemical exams or your labs, your clinical evaluation, and your dietary intake. So it's important to get a good medical history. We ask for the duration of illness and any relevant symptoms, and also ask for previous lab tests done, and present medications and treatment, and also get past medical history, hospitalizations, previous surgical procedures. And we also check for the growth patterns. We could check their baby's book, and try to see if there's a decrease in the growth velocity, and also ask for the patient's feeding abilities. Okay, because that will matter later on how you're gonna give your nutrition. All right. And also ask for the family background, what their usual dietary practices are, and try to see also, if there are any problems with swallowing. Okay, so symptoms of your oropharyngeal dysphagia would include drooling, choking every feeding, and that would probably be a sign that your patient needs enteral feeding. And also try to see for a check for GI symptoms like vomiting, and constipation. So included also with our history taking is a good dietary history. We'll try to check for the typical meals, of our patients, and refer. This is quite taxing, so I usually refer them to our dietitian, and the dietitian would compute for the estimated caloric intake, and also put there the macronutrient distribution of our patient, so we could have a better picture on how our patient is feeding. So this is a sample of your 24-hour diet recall form that our dietitians would usually make use of. So for physical examination, of course, we have to check the general condition of our patient, if the patient is stable or unstable, and also check for signs of malnutrition. Pallor could be a sign of anemia, rashes, could be a sign of micronutrient deficiencies, and so are your hair thinning, and edema, those are signs of malnutrition. And also check for organomegaly, So aside from the tumor that you could palpate, we also want to check for any other organomegaly. So anthropometrics would include your weight, and then also your length for less than 2 years old, and height for more than 2 years old. And for above 5 years old, we compute for your body mass index, which is your weight over your height in meters squared. And for patients whose tumors are quite big, and you think would affect or would give you would affect the weight, of the patient, then what is recommended is that we get your mid upper arm circumference, to detect for any signs of wasting. So we have our WHO growth charts for which we could plot our anthropometrics. And so for less than 2 years old, we get your weight for length and length for age. For those 2 to 5 years old, we get your weight for height and your height for age. And for more than 5 years old, we make use of your BMI for age and height for age. So these are just samples of your WHO growth charts, and you can download this for free. And this is how to interpret, your WHO growth charts. So for weight for length, weight for height, and your BMI less than -2, so that's already a sign of wasting. Then your patient has moderate acute malnutrition, and if it's less than -3, then your patient has severe acute malnutrition. And on the other end, if your patient is having a weight for length, weight for height, or BMI above +2, then that's a sign that your patient is overweight and probably obese if it's above +3. So your mid-arm circumference, a general measurement, or criteria for your severe acute malnutrition is having a mid-arm circumference of less than 115 millimeters. But we also have growth charts, for your mid-arm circumference for ages 3 months to 5 years old. So we could also make use of that. By using your growth charts, we are able to assess, the nutritional status of our patient, whether our patient has a normal nutritional status, our patient is overweight or obese, or our patient is stunted, if the height is affected, and if our patient has wasting, having moderate acute malnutrition for those with less than -2, and those less than -3 having severe acute malnutrition and severe wasting. So another tool that we could also use, is your subjective global nutritional assessment. So your subjective global nutritional assessment was first used in pediatric surgery patients to check for the risk of developing malnutrition during the hospital stay. Okay. And it has also now been used in certain conditions, pediatric conditions. Actually, we had one study done by a former pediatric resident on SGNA, in uh, in patients with leukemia. Okay. And she was able to validate your pediatric SGNA among those population of leukemic patients. And your pediatric SGNA, you could have a quick nutrition focused medical history. And what you check there is your linear growth, your weight relative to your length and height, any changes in the body weight, also diet and GI symptoms, and if there are presence of functional impairment and metabolic stress. So this is your sample of your pediatric SGNA medical history. And you also have a physical examination part of your SGNA. So what you just try to look for is any signs of loss of subcutaneous fat, muscle wasting, and edema. And by doing the checklist, you could be able to see if your patient has normal or moderate or severe risk for malnutrition. For diagnostic studies, nutritional assessment really is primarily clinical, and laboratory assessment may not be required depending on the signs of malnutrition that you're trying to check. Okay. So what's recommended really is to do your history and physical examination, because your laboratories are really non-specific for malnutrition. But for pediatric oncology patients, getting liver function and renal function tests can be of value. And also baseline lipid and glucose panel, especially before chemotherapy. And well, your albumin and your serum protein concentration will also give you a clue on how severe the malnutrition is. And in first world countries, they are able to get micronutrient levels, but that is not really practical in our setup. So management for our patients, malnourished patients with tumors, so first, again, as I've said, we do the assessment, and then after we did the assessment using your ABCD, method, then we could try to see, if our patient is adequately nourished, or having normal nutritional status, and consuming at least 60% of the recommended nutrient intake or caloric intake. Then what we recommend is just nutritional counseling, or to refer them to a dietitian, or to compute for diet for age. You'll see later on how to do that. If our patient is having no signs of malnutrition, but when you did your SGNA, the patient is classified under moderate nutritional risk, then we could also give nutritional counseling, diet for age, but it's recommended to give oral supplementation with your micronutrients, and even your oral nutritional supplementary formula, or or your high caloric milk formula. For patients who have already wasting, no, and meeting less than 60% of the caloric needs, no, needed, uh, it's recommended that we give nutrition through the enteral route. So either NGT, or if it's more than 3 months, probably recommend a gastrostomy tube, no, or PEG. And if the enteral route cannot be used, no, so in some rare cases, then parenteral nutrition is the only nutrition that we could give. So for those who have normal nutritional status and able to feed well, no, so we could make use of your Philippine dietary reference intake. So this is a dietary reference intake specifically for Filipinos, and you can find there, no, the uh, caloric requirement, no, or in energy, no, and also the other macronutrient requirements, no, for our patient depending on the age and the gender of the patient. And for macronutrients, no, for when we make a dietary prescription, no, it's important to make sure that we give the right proportions of carbohydrates, protein, and fats, no. So for Filipinos in general, no, I usually give around 55 to 60% carbohydrates, and then proteins is around 10 to 15%, and then fats is around uh, 20 to 30%, depending on the age. For younger kids, they need more fats uh, compared to carbohydrates. But for older kids, more than 2 years old, we would want to give lesser percentage of fat. So if our patient has severe acute malnutrition or wasting or severe wasting, then it would depend, no, if our patient is having complicated severe acute malnutrition or uncomplicated severe acute malnutrition. So when we say complicated severe acute malnutrition, those having a severe wasting and not able to feed well, okay, and having serious illness, no? So I guess uh, uh, tumor patients, no, are belongs to those with uh, those severe illness. So you might wanna need to admit the patient, and nutritional therapy in these patients, no, uh, would have three phases. So first is your stabilization phase, no, especially if your patient came in the emergency room, no, with unstable vital signs, then you have to stabilize the patient, no. But after stabilization, no, you could, if possible, you could start nutrition the earliest, no. So and then after a few days, no, of the initial uh, nutritional therapy, then we proceed to your transition phase, and then later on rehabilitation phase. So that would uh, differ, no, because in at the start we usually give lower calories, no, because we don't want your refeeding syndrome to happen, no, and most of the time your patient cannot tolerate a high caloric load at the start. So we usually gradually increase your caloric intake later on. So that is why in government hospitals, we usually start with F75, and then later on shift the formula to F100, which has a higher caloric content. So what's recommended for critically ill severe acute malnourished patients, is to use your indirect calorimeter. But unfortunately, we don't have that in the Philippines. We have in UPPJH, but I think it's in their museum. So if we don't have an indirect calorimeter, we could make use of your Schofield formula, no? And what is advised is to start at least 2/3, no, or around 70% of the computed caloric needs for your patient at the onset. So this is your Schofield formulas. No, you have there. What you need really is just the weight and the height, and you could and the age of the patient, and you could compute for the caloric needs for your wasted patient or malnourished patients, and start at 70%, no, and increase gradually by 10 calories per kilogram per day. What I do, I usually increase lang after 3 days, no. So instead of 10, then I increase by 30 calories per kilogram per day. And then until uh, your total protein intake per day is around 4 grams per kilogram per day. So we don't want to give too much protein, no, because your patient will down build. You need more energy to convert protein into glucose, and so your upbuilding will not be effective if you're giving too much protein. And then caloric intake usually is around, the max is around 150 calories, because if you give too much calories, and your protein intake will also increase. So they go hand in hand. And then we try to check for feeding intolerance, vomiting, uh, reflux, okay? And then also check for signs of refeeding syndrome, especially in the first 3 days of upbuilding. So if we give too much calories, then your patient might have uh, hypotension, hypoglycemia, and even cardiac arrest. Okay. And when we give bolus feeding, that's our usual feeding style. Okay. Take note of the gastric capacity for age. Okay. So it will depend really on the age of your patient. But for adults, the maximum is around 400 ml per day. In my patients, my maximum is around 200 to 240 ml every 3 hours. Okay. So what to give for ages less than 6 months? No, so if there's no wasting, give breast milk or milk formula. If there's wasting, then probably supplement your breast milk with a catch-up formula. So we have available catch-up formula in the market. For those 6 months to 2 years old, no, if there's no wasting, then of course we continue breastfeeding or the milk formula, but we make sure that the patient is getting the appropriate complementary feeding for age. If there's wasting, then probably give breast milk plus catch-up formula. And for those 2 years to 5 years old, if there's no wasting, then diet for age, and then just give high caloric milk formula or your oral nutritional supplementary formula. And then if the patient has wasting, then we give if the patient is admitted, then we give F75 at the onset and shift to F100 later on, if they're admitted in government hospitals. But if they're admitted in private hospitals, so we don't have available F75 and F100 outside government hospitals. So what we make use is your oral nutritional supplementary formula. For those beyond 5 years old, then we could probably give both your diet for age and oral nutritional supplementary formula. There's no wasting, no. But if there's wasting, so especially if your patient can only tolerate enteral feeding, okay, or NGT feeding or G-tube feeding, then we could only give your oral nutritional supplementary formula. So this is your nutritional content of your breast milk. So the average calories per 100 ml is around 65 to 69 calories. That's around 20 calories per ounce, no? And it's also like that for regular milk formula, no? Regular infant milk formula. And sometimes, no, for certain patients like preterms, no, we could probably make use of your preterm formula if breast milk is not available. And if those who are not breastfeeding, no, or even if they are breastfeeding, but you have failure to thrive, no, or malnutrition, then we add on your catch-up formula. Those having diarrhea, no, because of lactose intolerance, malabsorption, or even galactosemia, then a lactose-free formula would be appropriate. And if those having uh, constipation, colic, reflux, no, in which is also quite common among malnourished patients, no, then a comfort formula can be recommended. For those having signs and symptoms of cosmic protein allergy, like your atopic dermatitis and vomiting of hematemesis and hematochezia in formula-fed patients, then maybe you would want to give an extensively hydrolyzed milk formula. Elemental formula, no, are usually reserved for those having severe malabsorption and short bowel syndrome. And of course, you have there your pediatric formula or your high caloric formula or oral nutrition supplementary formula for those having wasting, no, moderate wasting and severe wasting. So if your patient has no signs of malnutrition, then we could probably recommend your pinggang Pinoy, which is an easier way, for lay people to understand what food to eat. So if they eat their go, glow, and grow food in the right proportions, then usually they get the calories, the macro and micronutrient that are needed for their body. Okay, so especially, but this is maybe quite difficult, especially for picky eaters. Okay, you wanna make use of your dietitians, no, in your hospitals, no, or in your locality, no, to help you with those kind of patients. So when we make a dietary prescription, no, so it's not enough just to put their diet for age or soft diet or milk formula, no. So it would be better, no, if you would make a dietary prescription so that the dietitian would be guided, no, on what type of diet or uh, what type of diet that your patient needs. Okay, so the components usually for a dietary prescription, no, first is the type of diet, no, if what you want is diet for age, soft diet, or blended rice feeding, no, and you also have to put there the total caloric intake, no. So if your patient has no signs of malnutrition, then you could make use of your PDRI, no, or Philippine Dietary Reference Intake requirements of per age and gender, no. But if your patient is malnourished, then you might want to make compute first for the caloric intake using your Schofield formula. And then also put there, no, your acceptable macronutrient distribution range, no? So how many percent carbohydrates, proteins, and fats, no? So that would depend on the age of the patient again and the uh, condition of the patient. So if you need low fat diet, then you probably bring down the percentage of fat that you want to give. If you want to give high protein, but the max really for Filipinos is around 15%, no? Okay, or low carbohydrate diet, no, or low sugar diet, and just put there the percentage uh of that macronutrient, and the total should be 100%. Okay, and you also have to put there the number of feedings per day. So usually if it's diet for age, then 3 meals and 2 snacks per day. But if the patient is on NGT feeding, so usually it's around every 3 hours or every 4 hours, no, initially. Okay, so just sample computation, no? So if we have a 1-year-old male patient who is 10 kilos and having a height of 75 cm, so that's normal for his age, okay, the weight and height. So we wanna order a dietary prescription, no? So we put there the total caloric intake. So for 1-year-old, it's around 1,000 calories per day, no? And if we give 60% carbohydrates, protein 10%, no, or fats 30%, no, and just put there 3 meals and 2 snacks per day. So just remember now, for every gram of carbohydrates, no, that's around 4 calories, no, and for every gram of protein, that's also 4 calories, and for every gram of fat, so you have there 9 calories. Okay, so for another patient, no, so for that patient, no, that's how we computed, no, so 1,000 calories per day. And if we decide to give blenderized feeding, so it's the same thing, just put their blenderized feeding, and then the percentage of kanang your macronutrient distribution range, no, for your carbohydrates, protein, and fats. So for soft diet, then we could still give 3 meals and 2 snacks per day na soft diet. But for blenderized feeding, if you want to give through NGT, no, or G-tube, then we could probably order their 6 to 8 equal feedings per day. So what if our patient has wasting? So example, no, if you have a 3-year-old male with hepatoblastoma and poor appetite, so when you take your when you took your anthropometrics, no, so the weight for height is less than -3, and the height for age is less than -3. So that means your patient has severe wasting, no, and severe stunting. So that's considered severe acute malnutrition. So in this patient, because the patient has poor appetite and also severe acute malnutrition, then probably it's best to give your feeding through enteral feeding, no, NGT feeding. And by using your Schofield formula, no, so this is how we computed. So we got around 450, around 630 calories per day. But initially, we want to start low. So we give 70% of your Schofield formula. Then that's around 450 calories per day. So if you divide it by 8, that's more or less around 60 ml every 3 hours. No? And then, of course, we want to increase as tolerated, no, by 30 calories per day every 3 days. Okay, so that's around 10 calories per kilogram per day. Right. So lastly, no, in our patients, aside giving them the appropriate caloric intake, no, and also appropriate or acceptable macronutrient distribution range, no, so the percentage of your carbohydrates, protein, and fats, we also want to give them your macronutrient supplementation, because patients with malnutrition or severe wasting or even moderate wasting, no, also have micronutrient deficiency. And in oncology patients, no, even if they don't have wasting or yet, no, they are at risk or even have already beginning micronutrient deficiency. So what's recommended, no, is probably to look for a multivitamin supplementation preparation that contains your vitamin D, B complex, no, vitamin C, zinc. If you could also give selenium, glutamine, and omega-3 supplementation, that would be of help, no, in our patients, oncology patients with uh, malnutrition, no, or even if without malnutrition, but they're already going to undergo chemotherapy. No? So your micronutrient supplementation helps. So I guess this is my last slide. So before we end, so what the take-home message is that the take-home messages are that nutritional status matters. So you have to assess, especially your pediatric oncology patients during the start, no? So you have baseline assessment during therapy and also after chemotherapy, no? So, and then after assessing your patient during those times, no, then we have to give the appropriate nutritional intervention. So if there's no wasting, your patient is feeding well, then we give your diet for age using your Pinggang Pinoy, no, or your Philippine Dietary Reference Intake Values. But if your patient already has is at risk for malnutrition, refer them to a dietitian and probably give your micronutrient supplementation and your oral nutritional supplementary formula, no, or your high caloric formula. But if your patient already has wasting, no, or severe wasting, then enteral feeding is usually appropriate, and we give either F75, F100, or your oral nutritional supplementary formula through NGT, no, to make sure that our patients wasting, no, is addressed, no, right away, because if we don't do that, then your patient is at high risk for morbidity and mortality. So thank you for your attention.